Just a few housekeeping items. First, this webinar has been NVC approved for one scientific credit. Within about 24 to 48 hours, you will receive an email on how to obtain the credit. And we do record all of our webinars. So you can expect the webinars to be posted onto our website within about 5 to 7 days. If you have any questions throughout the webinar, we will be answering them at the end of the session, and you can write them in the questions box on the right-hand side of your screen. Now I'd like to introduce Dr. Michael Melkers. He is a graduate of Marquette University School of Dentistry. He and his wife, Dr. Janine McDonald, practice general dentistry in Spokane, Washington, with an emphasis on comprehensive and restorative care. Dr. Melkers is the founder of the Nuts and Bolts Occlusion Programs and is past director of Occlusion and Aesthetic Dentistry at the Pacific Northwest AEGD Residency Program. He is a member of the Pankey Institute and visiting faculty at the Spear Institute. He has presented and published around the world on occlusion topics, communication, and restorative dentistry applicable to everyday and someday practices. Dr. Melkers?
Canada, Singapore, Peru, Chile, and the United States. I'd like to welcome you to the webinar this morning that we'll be presenting, which is intention-based orthotic therapy and really a logical approach to treatment success. Now, what I'd like to share with you is some of my experiences in successes, challenges, and really what's allowed me to successfully implement orthotic therapy into our practice. As Sarah introduced, I'm a general practitioner in Spokane, Washington. I do maintain a private practice as well as my teaching, and I'd like to share that with you that I'm just not paying my bills with my lecturing. I have the same challenges that many of you do as far as with my patients, with my team, with insurance companies, and clinical challenges that we face every day. So to give you a little bit of a snapshot of my practice here in Spokane, as far as my side of the practice goes, you can see that I'm heavily restoratively based, but I also have a fair amount of implants, and I have a pretty large percentage of my practice being occlusion and orthotic related. So I'd like to share with you how we've successfully implemented that into our practice to such a high percentage and made it something that's not only fun for us but rewarding professionally and a value for our patients. Now when we look at orthotic therapy, and I said intention-based orthotic therapy, I'd like to really approach this from a little bit kind of different perspective. Rather than a pure technical approach, this is a best bite, this is a Whitmix deprogrammer, this is a Tanner, this is a universal. What I'd like to talk about is not what we're using, that is not just what the physical modality is of orthotic therapy, but the intention, that is why we do what we do, the design somewhat, how we do what we do, and then the expectation. What can we expect out of the why we do what we do and the how we do what we do, and how can we bring that together with the patient's goals. First, I'd like to start off with intention. Now, when we look at just the myriad, the plethora of orthotics that are available on the market today, we have hard splints, we have soft splints, we have hard-soft splints, we have full splints, we have partial coverage splints that go on the posterior teeth, that go on the anterior teeth. We have splints that go on both arches. And how do we really wade through this? I think that when I got out of school, the only splints that I was really familiar with was a hard splint and a soft splint. With the explosion of the popularity, the resurgence of occlusion for pain issues, for protection and aesthetic issues, we have more choices than we've ever had. And it's also become somewhat more confusing than it ever possibly could have been. So I'd like to unravel that a little bit from a different perspective. When we started out in our orthotic and occlusal splint education, it was a very technically centered doctor-based approach. When we looked at the intention as well as the methodology and the goals of splint therapy, we talked a lot about the correctness of position. We talked about test driving occlusions. We talked about determining and confirming correctness of positions. And Dr. Dawson really laid the foundation for this, for us to really understand and implement orthotic therapy. While this is a great definition, one of the concerns is, what do we do with this? What does this mean to us, and what does this mean really for our patients and for our practice? One of the people that really clarified this, and a mentor that really helped me understand orthotic therapy, was Dr. Tim Delina and his article in Journal of Prosthetic Dentistry in 2001. And he really put it into bullet points. The purpose of occlusal splints is to relax the muscles, make them feel better, to manage that pain. We could use that in the more traditional sense to allow the condyles to seat to centric relation, if that's important to us. That can provide us with diagnostic information, whether through relaxing the muscles, through seating to CR. And during all this process, we certainly want to allow the teeth and joint to not get beat up and not get damaged. So this really pushes us forward with the intention of, when do we do what? When do we use each of these? Dr. Henry Tanner said, we treat what we see what we know, so what do you see? And we certainly see these two patients with some moderate to severely worn dentition, but what are their concerns? I show you here a picture of a beachhead, and actually this is a beachhead in Australia. When you think of beaches in Australia, you think of Sydney, maybe you think of Bondi, you think of white sand and blue water. You really don't think about what this looks like and how dangerous this is. This is along the Great Ocean Road. It's called the Shipwreck Coast. And it's kind of how we can look at our patient's mouth, and we see all the dangers, and we see these cliffs here that are 60 to 90 feet tall and these waves crashing over the sides. And we can see the dangers that come along with those severe wear cases that we saw on the previous slide. But when we look at our patient's perspective, perhaps, that's what they see. And that is actually the same view of the same beachhead. As you look there, you can see through the opening on the right, that little bump here is the same bump that you see on the right side of the screen. And that's really a matter of perspective, of intention. And sometimes that intention is the patient's not understanding what's going on in their mouth. But sometimes it's our lack of understanding of patient priorities. So taking that forward a little bit, let's look at a couple of patients, or a few patients here. And one of these patients comes in to our practice and says, I can't eat. Another one of these patients says the pain is unbearable. And the third patient comes in and says, I want the smile back that was stolen from me. So I guess I'll ask, which of these patients is which? We can certainly see that there may be some indication for splint therapy in all of these patients, but is that based from a doctor-centered approach or a patient-centered approach? Because the difference in those approaches will directly affect how patients accept and proceed with treatment. So when we look at those three patients, and we look at really those three groups of patients, we're really looking at three types of patient-centered concerns. Patients have pain that they'd like to get out of, and we can offer palliative therapy. Patients have teeth that are being blown apart, they're being worn down, they're breaking, they're being destroyed, and we can offer protective therapy. Or we have patients that need to figure something out, need to figure out why it's hurting, why it's been destroyed, why their smile's been stolen from them. And as they proceed with restorative care, we need to really look at this from a diagnostic phase. Years ago, decades ago, Dr. Albert Schweitzer said this quote. he said, patients carry within them their own best doctor. They come to us not knowing that fact. We are at our best when we allow the physician who resides inside of each patient a chance to go to work. I'd like to show you how Dr. Schweitzer's quote and the triad of intention of splint therapy of palliative, protective, and diagnostic can be applied to a patient base. And I'd like to introduce you to one of my patients, and that's Dave. Now, Dave came to our practice, and you're all looking at Dave's teeth and probably already formulating perhaps some treatment plans in your head. And, you know, what do you think Dave's chief concern may be? Some of you may say, short, ugly brown teeth. It's aesthetics. It's what the majority of us will say. Some might say, well, maybe it's the perio situation there in the lower anteriors. And some might say, well, maybe it's the gingival architecture and going back to aesthetics. But I'll tell you that the only thing that I knew about Dave really when he came to our practice was that I was the sixth dentist he had seen. And I don't mean the sixth dentist he had seen in his life. I mean, I was the sixth dentist that Dave had seen in the last month and a half for a comprehensive exam and records. And I start to think about intention. And I said, Dave, why are you here? First of all, I introduced myself. I said, hi, I'm Dr. Melkers. He said, hi, I'm Dave. And I said, Dave, what brings you in today? He goes, well, just want to know what you think. And I said, well, I think I'd like to know why you're here. What can I do for you, Dave? And he goes, well, the last guy wanted to cut my gums and put some crowns on. And I said, okay. And he said, well, the guy before that wanted to move my teeth around, didn't think he needed to cut the gums and then put some crowns on. And I said, oh, okay. He said, well, the other guy wanted to do some braces. And I said, Dave, why are you here? And he said, well, what do you mean? And I said, Dave, I don't know a lot about you, but I do know that I'm number 6. I know I'm the 6th dentist that you've seen in the last 90 days. Why are you here? And Dave looked at me and said, are you serious? And I said, yeah, I'm very serious. In fact, I'm not getting out of this chair because if there's going to be a number 7, let's just shake hands and go on our way. But what I'd really like to know, Dave, is why are you here? And Dave looked at me and he started tapping his keys on the table. Underneath the table in the consult room, he had actually been holding his ignition key between his thumb and forefinger, ready to leave. I had lost before I'd started. And he said, are you serious? And I said, yeah, I am. And he said, I have short, ugly brown teeth. You know it, I know it. You can see it across the room. I said, okay. Why are you here, Dave? And he said, I can't eat. And he tried to open his mouth, and he could open his mouth maybe only about 12 millimeters. He goes, everybody was trying to fix my smile. Everybody was trying to make my teeth pretty. The thing is, Dr. Melkers, I can't eat. I can barely open my mouth wide enough to get the food in. When it's in, it hurts to chew. After I chew a little bit or hurt so much, I go ahead and swallow it. I'm not digesting well. There's nothing good about eating for me. It hurts going in. It hurts going out. I can't eat. And I said, Dave, that sounds terrible. I said, what can I do for you? And Dave said, can you make it so it doesn't hurt when I eat? And I said, I'd love to try. And that's where our orthotic therapy became, let's make it so it doesn't hurt when Dave laughs. But all of us are very clear on what the intention is. If we wanted to be fancier, we might be calling this palliative diagnostic orthotic therapy. But the intention really is to affect Dave's muscles so they feel better, so that he can open his mouth wider, so that he can get food in his mouth, so that he can chew, and so that he feels better when he chews and he feels better when he's digesting. So it doesn't hurt when Dave eats orthotic therapy. That becomes our intention. Now, as we move forward with Dave, we try out what we know at the time. And here we have an NTI, and made on the lower, and Dave tried that out. He came back in a couple of days, and he said, I can't wear this. And I said, why is that, Dave? He said, I'm going to swallow it. I'm going to aspirate it. It'll go in my lungs. Something bad is going to happen. And I said, okay, well, let's try something else. So we tried a full arch design, and this overcame Dave's concerns about aspiration or swallowing. And our intention, that is our palliative intention, stayed the same, even though our design changed. And Dave started feeling better, and his muscles started feeling better, and he started being able to open wider, and he started being able to chew more. And that went on, and life was pretty good for Dave. You can see we have a full arch splint, highly polished, quite low profile, some semblance of anterior disclusion. We'll talk about that in a bit. But one day Dave came in to hygiene, and I said, how's it going, Dave? And he said, it's going great. And I said, tell me about great. He goes, I can open, look at this. And he opened wide, and he goes, and he slammed his teeth together a few times. He goes, feels good chewing, everything's good now. And I said, is there anything else? And he kind of smiled, knew I was maybe referring to his smile. And he says, not yet, I'm not ready for that yet. He goes, oh. He goes, but there is one thing. He goes, there's a rough spot. I was wondering if you could polish. And Dave pulls this portion, if you can see on the left. And this is the rough spot he's referring to. And I'm thinking, oh no. I said, Dave, where's the other part of the rough spot? And he goes, oh, that's in my pocket. And he pulls out this portion here. And I'm thinking, oh great. I have to intraorally lute and repair a full arch appliance. And Dave's thinking, well, couldn't you just smooth it off here, Dr. Melkers? I said, well, Dave, I could, but on the other side, you also have a fracture. And he goes, well, why don't you cut the other side off in the back and make it like that first one that you made me? And, that's what we did. And not much had changed as far as our intention, because whether we're looking at the NTI that we began with, the Tanner that we transferred to, or the anterior midpoint stop appliance that we ended up with, the intention remained the same. That is, palliative diagnostic therapy to make it so Dave could eat without it hurting. That is where the design becomes somewhat irrelevant, or the design is really just a vehicle that serves our intention. So when we look at that and we make that bridge when we're talking about what Dave's goals are into the design, let's look at the intention and wrap up the intention phase, that the purpose of occlusal splint therapy is palliative. If we're in pain, patients in pain, let's get rid of the pain. Protective, if something is being destroyed, let's do our best to protect it. And diagnostic, if there's something that we need to figure out, can the appliance help us do so? And with that, let's move into design. When we look at design, again, we have just this plethora of design choices: full arch, hard, soft, upper, lower. And where do we begin? When we look at what's available on the market today, we have anterior segmental appliances on the upper left. We have dual arch anterior segmental appliances on the lower right. We have full arch splints on the lower left. We have Tanner appliances on the upper right. And I guess when we think about this, as we move from intention into design, the question I'd like to ask is really, what do we expect the orthotic to do? And we've gotten into the palliative, protective, and diagnostic, but I'll ask, how do we expect it to do that? Well, the advantages of an anterior design, I'm going to start there, is the anterior design allows the condyles to seat. It reduces contractile muscle activity by 70%. These are really easy to fabricate. And if we look here on the left, we have one of the Dana deprogrammers in place. And this is tried and true appliance therapy. It goes back to Victor Lucia. It goes back to the Lucia jig. It goes back to the leaf gauge. All sorts of anterior appliances and why the advantages of them exist. This list is actually a distillation from Dr. Dawson's textbook. Allows the condyles to seat, reduces muscle activity. They're easy to make. They're easy to wear. They're easier to get posterior disclusion, and they can easily facilitate transition to other therapy. So when we look at this, I'd like to, really explore and focus on one of these, and that's going to be the reduction of muscle activity. So why do anterior appliances work so well? And there was a study done by Dr. Erwin Becker, Greg Tarantola, and Zambrano that was published in the Journal of Prosthetic Dentistry back in '99. And it said the use of a modified anterior midpoint stop appliance reduces or can reduce voluntary clenching intensity to 1/3 of maximum. Now, what I'd like to do to really take this point home is I would like for us to recreate that study here, right here on this webinar. So when we do that, each of us is going to become the clinician and the test subject. And I would ask that you don't jump ahead here with me. And please feel free to follow along. I'm not there in your office or clinic. I'm not going to bite your finger for you. So, but I don't want you biting on your nail bed. I'd like when you actually get around to the test to actually just bite up here more on your fingertip. So the first thing we're going to do is we're going to, down here on the lower right, I'd like you to take your finger and go all the way back to your second molar, most posterior tooth, not third molar if you have them. Let's just work with second molars if you have them. And what I'd like you to do is just tap, tap, tap on your back on that nail, and then just once and only once, try to bite as hard as you can. Okay, and stop. If you haven't stopped, go ahead and stop. Now, some of you tried to start biting and your body wouldn't even let you. Some of you didn't trust me, that's okay, and probably didn't even bite at all. Others of you started to bite, and before you even realized that it was hurting, you stopped. Is that a fair assessment? Is that what I'm hearing from the attendees? Good. Okay. Now let's go up to the canine or the cuspid here. And what I'd like you to do is go ahead, this time take a different finger, go ahead and put it underneath the canine, tap, 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 and once, just once, try to bite as hard as you can. And stop. Now that time, some of you tried to bite as hard as you could and it hurt, and you thought, wow, that hurts, I'm stopping. You didn't have the reaction that some of the others did, where they tried to start and their body stopped them before they even realized. What we were experiencing here, what we experienced on the second molars, was really fight or flight syndrome. If you're barefoot and you step on a carpet tack, your body pulls you away before you even realize and register that pain in your conscious brain. You're reaching for the kettle on the stove and you get a little too close to the hot metal or the flame, your hand comes back before you even realize it. That's what you experienced on the second molar. On the canine, you didn't experience that. Maybe I would say about 20% of the group didn't experience that. And they thought, wow, this hurts, I'm going to stop. So let's jump up to the third one, which is the centrals. What I would like you to do now is take a third finger and tap, 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 and bite as hard as you can. Go ahead, really bite into it. Come on, bite, bite, bite. Okay, stop. Does everyone have 2 dots on the pad of your finger? What you just experienced was not only that reduction in muscle activity that Becker, Zambrano, and Tarantola showed, but what you just experienced was the whole rationale for anterior guidance. And as we move to this next screen, what I'd like you to look at, because this is an EMG more or less of what you just did. And here, if we're going in the peaks from left to right, is I had a 3-lead EMG on my temporalis and I bit as hard as I could. Then I put something between my centrals and I bit as hard as I could, and I was knocked down by about 70%. Laterals to laterals, canine to canine, premolar to premolar, and molar to molar. What I would like you to realize and recognize is not the difference between that far right molar recording, EMG, molar recording, and the second from the left, incisor recording. What I would like you to look at is how incredibly similar the canine guidance is and the canine EMG muscle activity is to the posterior teeth. That's why sometimes we see these full arch appliances bruised and we see them damaged. Sometimes when we restore a patient and we give them canine guidance, we're still fracturing canines. One of the reasons is we're still about 70% muscle activity when they're in that premolar canine area. It's not really until we get up to the centrals that we drop that down.
Hey, Dr. Melkers.
So great. Yes.
I want to interrupt you just for a quick second. It
Sure.
looks like you're having a little audio problem. You're sounding a little distorted.
All right. Is that better?
No.
I haven't changed it. I haven't changed position.
Ooh. It keeps on getting a little worse.
Is that better at all?
No. Is your microphone plugged in all the way?
My microphone is plugged in all the way. So, check 1, 2, say, is that working or is that still fading in and out?
Yeah, you're very, Do you want to try switching over to the telephone and see if that works a little bit better?
I can do that. What number do I call?
If you look on your audio or your side panels, there is a tab that's called audio. That'll let you do speaker and mic, or if you click the telephone, it'll give you the phone number and your access code.
Sarah, can you hear me okay now?
Yes.
Okay, I'm using my Mac, and is my screen showing?
It is.
So we're on play again?
Yep, everybody's here.
Okay, I apologize everyone for that. Let's see. I can't see my blue screen or my gray screen or any of that anymore though, but I can see my keynote. Apologies everyone for that technical difficulty. I think we're back up and running, and Sarah, if you could let me know how I'm doing. As far as audio goes, we'll go from there.
All right, why don't we just start where this slide is.
Okay, so we didn't get really anything from this?
It was pretty choppy at this point, so we can just, do you mind starting from the beginning of this slide?
Did we get through the finger biting already?
Yes, and
Okay. So what you experienced there was really the rationale for anterior guidance. And what we have here on this EMG is we have a 3-lead temporal EMG where I'm clenching my natural teeth together. Then I put something between my centrals and clenched, lateral to lateral, canine to canine, premolar to premolar, and first molar to first molar. And what I'd like you to see really is not only what is not just the reduction between a molar hitting and the anterior. What I'd like you to look at is the similarities between the peak of the canines touching, the premolars, and the molars. That is, sometimes when we have full arch appliances or we restore canine guidance, we see broken appliances, gouged appliances, and even fractured canines. So what we have, where we've heard and we've been taught about canine guidance, there was another element to that, was canine-initiated disclusion with an immediate transition to a more anteriorized contact. That is the whole rationale for anterior guidance, and it is one of the rationales for anterior appliances, and it is one of the rationales for having anterior guidance on even full appliances. So when we look at anterior appliances, and here we have an anterior midpoint stop appliance, and here we have a full arch appliances. On a full arch appliance, we have dots in back. Both of them have lines in front. And I would ask, which would you rather equilibrate? Because the design and the methodology are the same for both once the patient is in motion. I hope that clears up a little bit some of the design controversies, because full arch appliances are fantastic and they've served the profession and patients well. But as soon as that patient is in motion, as soon as they're grinding around, there is really no difference between the design of the full arch appliance and the anterior only appliance. The big differences, though, are ease of fabrication, comfort in use, and comfort in adjustments, ease of adjustments. Finally, I'd like to move on to expectations. And within those expectations, I'd also like to discuss fees and timeline a little bit. So we've had the intention of orthotic therapy, that is palliative, protective, diagnostic. We've talked about design a little bit, and specifically focusing on anterior disclusion, that is discluding with the anterior teeth, whether we're on a full splint or we're on a partial coverage design.
Dr.
Now I'd like to, yes?
We lost your screen. When you went to switch slides.
Can you give me control of the screen again? Because I don't have that anymore. Is that up now?
There we go.
There we go. All right, we got it, and I have my blue and gray screen back. All righty, thank you everyone so much for being so patient with a couple of the technical difficulties. I know that we have a bit of a storm here in Spokane, and I'm wondering if that's affecting things. All right, so expectations, fees, and timeline. I saw this post online, and I saw this on Dental Town, and here we have a protective orthotic, or you could call it a bite guard, you can call it a night guard, whatever you want. But we have it after a couple of years and it's broken. And the poster on the thread said, so most of you guys are charging again when a night guard breaks after a couple of years. How can you justify the money the patient just spent on something that only lasts for a few years? I would like to really explore that, because we have intention, we have in design. Now I'd like to talk about expectation, and I'd like to talk a little bit about value. And I'd like to introduce you to another patient of mine, and that's Josh. Now, if you look at Josh is a new patient in our practice, and this is the way he presented. His hygiene is pretty good. Gum tissue is looking pretty good. He obviously has some anterior work there. But when you look at Josh a little closer, this is what Josh looks like. And we look at the extreme wear and the extreme damage on Josh's teeth. And one of the things I'll ask you is, what sort of treatment does Josh need today? What is Josh's prognosis if left untreated? Because I'll tell you, one of the things that you don't know is Josh is 24 years old. And I'd like to think about really what is Josh's outlook when he's 30, when Josh is 40, and when Josh is 50. Because if we look at this and we look at Josh's appliance and we look at his dentition and his current and future treatment needs, what value do we place on prevention? And if I ask you, and if I surveyed the attendees and asked perhaps what sort of treatment would you provide for Josh today? Some would say nothing. Some would say an appliance. Some, as we've surveyed in past webinars, would do a little resurfacing with composite, perhaps some equilibration. Some would jump all the way to crowns. And there would be a large argument of which one's right. But if we could put the argument aside and really look at Josh's prognosis of what will happen if left untreated, we can see that eventually those teeth will wear more. We can see that they will possibly super erupt. We can see that pulps could become exposed. We can see that restorative treatment or endodontic treatment or even tooth loss is a possibility. And we go back to that broken appliance and we talk about the intention, which is protection, and we talk about the expectation is what is that intention supposed to do? It's supposed to protect. The appliance is an airbag. It's supposed to take the damage that would have happened to the teeth. So in this case, that appliance that patient perhaps had to pay for again in a few years has prevented the composite work, that root canal work, the ortho work, the crown and bridge work. And when we look at that, progression, really one of the values, especially in the protective intention of orthotic therapy, is that we can become agents of change. We can become that stop sign that early and ongoing intervention can prevent extreme and catastrophic dental needs and associated costs. So I'd like to put that in a little perspective of what patients see and what we see, and take this away from orthotic therapy just for a second. Because patients see what they know, and they treat what is of significant consequence to them. So from a financial standpoint, I'd like to talk about what the consequence is. And let's just look at this tooth here. And just for argument's sake, can we say at one point in this patient's life that perhaps that could have been addressed by a tooth surface restoration? From past attendees, I've gotten some fee ranges, so depending composite or amalgam, perhaps that's how much we charged. And they thought about it. And at some point it became a 4 surface. And it didn't hurt, and it wasn't affecting their function or aesthetics, and they thought about it some more. And they thought about it some more. And some more. And eventually that tooth was fractured and that tooth was lost. When we think about the catastrophic elevation and escalation not only in treatment needs but treatment costs, here we can see a 40 to 50-fold escalation in treatment costs. What value do we place on prevention, and how can we communicate that with our patients? Especially in today's economy, especially in today's global economy, more challenged than we've ever been, we have patients living longer, and we have patients doing more destruction to their teeth than ever, whether it's Starbucks or sour gummy bears or Rockstar, Red Bull, patients living longer, more abrasive toothpastes. They're having more catastrophic needs than we've ever seen, and they have less ability to pay for them. So I'll say that for patients with financial concerns, fixed incomes, and you can go ahead and read it there. Aggressive understanding, diagnosis, and treatment planning is indicated so that they can best understand their treatment needs and make appropriate decisions for their long-term health. Because I'll say that if they can't afford it today, they're not magically going to be able to afford it tomorrow. And one of the best things that we can provide for our patients is orthotic therapy and become those agents of change and provide early intervention to provide escalation and catastrophic needs down the line. And as we fold together that the expectations with the design, with the intention, we can go back to those 3 patients that we saw at the beginning, and they can eat, and their pain is gone, and they do have that smile that was stolen from them. I'd like to thank everyone for your patience this morning with our technical challenges, and I hope that was helpful. You can find some more free resources at whitmix.com. They have a wonderful backlog of other webinars, and this one will be archived soon, I do believe. You can also find some free videos at Dr. Melkers seminars on Facebook, also with my contact information. I'm happy to follow up with you, whether it's on email, Facebook message, or phone, whatever works best for you. But I would like to thank all of you for attending this morning or afternoon or evening, depending on where you are in the world. And I'd like to thank Whitmix so much, and Sarah especially, for their commitment to continuing education and providing this venue for us to share around the world. Thank you very much. At this point, I guess, Sarah, we're going to be taking some questions. I think that we finished a little bit early.
We did finish a little early, so we do have some time for questions. So at this time, if you'd like to write them in the questions box, we'll go ahead and answer them. But while everybody's doing that, I just want to remind everybody that the webinar is recorded and available for CE credit. So it's in about 24 to 48 hours you'll receive your email on how to obtain your credit. And again, the website, or you'll be able to find the webinar on our website in about 5 to 7 days. And what we will do, since we did have a little technical difficulty, we'll try to edit that out as much as possible so you get a nice seamless presentation. We did have a question come in that says, do you see a use for soft night guards?
The question being, do you see a use for soft night guards? I did a lot of soft night guards when I first got out of school. I probably did several hundred my first year and a half out. And I'll tell you, they were a great service to patients, no matter how little I knew about occlusion or orthotic therapy at the time. We got something between the patient's teeth, and they protected their teeth. There was a study that was done, I believe, by Dr. Okeson that showed the use of soft splint therapy can increase bruxism in 50% or by 50% of the patient base. Now, when we look at that study, I believe there were only 6 patients in that study. Dr. Okeson is a great mentor and a wonderful resource, and I'm not discounting his study at all. There are people that soft splints can help. Unfortunately, there is especially if we're dealing with muscle pain patients, and we put a soft appliance in there that isn't properly balanced, it can actually increase the resistance and muscle activity and increase their pain level. From a protective standpoint, whether from an athletic guard or from a quick and dirty protective appliance, as long as it doesn't increase symptomology, I am perfectly fine with the soft night guard. And that is a big turnaround for me from my previous opinion.
All right, that is actually the only question that came in. So I'm going to go ahead and end today's webinar, and if any questions do arise, oh, we've got one that just came in. It says, I understand how anterior guidance discolludes the posterior, but could you use clarification on what cuspid rise does the patient, or does for the patient? Do I need to reread it?
No, I'm just gathering my thoughts together. Traditionally, that's what we all learned was canine rise, cuspid guidance. Cuspid guidance still allows for approximately, this is just a rough ballpark, but about 75% of temporal muscle activity. The canine is also one of the strongest, longest teeth in the mouth. So when we talk about canine guidance, you can say canine initiated disclusion with the strongest, longest tooth in the mouth that probably won't break until we can move that guidance to a more anteriorized tooth, that doesn't use as much muscle activity. Now that doesn't flow off the tongue real well, so what we're doing is we're initiating our disclusion with a very strong tooth. That very strong tooth, however, still has a great amount of muscle activity associated with it. So let's get up to a more anterior tooth and drop that temporal activity down to 30%. That is the canine-initiated disclusion with the immediate transition to a more anteriorized contact. The other aspect of canine guidance, though, is resistance. If we can keep that canine guidance very shallow, perhaps we can minimize the consequences of that high muscle activity. It's a little bit difficult to answer that question without some graphics.
Okay, well, no other questions have come in.
They're going to trickle in.
Okay, here's one. Do you suggest this for patients with no pain but who do clench and who are getting, oh, my pronunciation is going to be horrible, Resio, R-E-S-S-I-O, or some wear?
So if I understand the question, it's patients that have no pain but have wear and recession?
I believe so, yes.
Okay. I've been using some sort of anterior appliance in my practice. I wouldn't say exclusively, but I would say in over 95% of the cases for patients that are symptomatic, asymptomatic, pain patients, protection-only patients, and really I've had wonderful results. They're easier to wear, they're easier to fabricate, they're easier to adjust, and if a patient is grinding, that is, if they're moving around, there is really no difference between a full arch appliance and an anterior-only appliance. The times that you don't want to use an anterior-only appliance is if they're going to be wearing it 24 hours a day, 7 days a week, or if you want to test drive out an occlusal scheme on the appliance. I certainly do go through a screening process that will help us uncover the possibility of an anterior open bite that may occur with an anterior-only appliance. But I will say that the worst anterior open bites that I've seen develop have been from full arch splints. Because whether it's a full arch splint or an anterior-only appliance, if one of the intentions of a full arch splint is for it to be a CR or centric relation splint, and the joint seats, we will see occlusal bite changes, whether we have an anterior-only appliance or a full arch splint. I do have that screening video, I believe, on Dr. Melkers' seminars on Facebook.
All right, well, thank you. I guess this will conclude our webinar today. And again, thank you for everybody for attending and your patience with our technical difficulties. And I hope everybody has a great day. So thank you.
Thank you, Sarah, and thank you, everyone.
Bye.